Welcome, faculty, students, and prospective candidates and alumni. I'd like to take a few moments to thank you for joining us today for this amazing learning experience. And as your MAPSA Executive Board member and also your MPH Online Student Ambassador, it is my responsibility to help seek out events that represent our students' interests. USC MPH students are extremely interested in our nation's opioid crisis, and they desire to learn more about how to address this issue as public health professionals. With the CDC's March announcement of a national 30% increase in overdoses from 2016 to 2017, this discussion could not be more timely. It is an honor to introduce today's hot topic speaker and educator, Dr. Ricky Bluthenthal. He is not only faculty in our Preventive Medicine Department and MPH program, but a research expert and authority on our nation's opioid epidemic. We are very fortunate to have him as one of our professors, and please join me in welcoming this amazing guest. We are sure to learn a lot from him. Welcome, Dr. Bluthenthal.
Thank you for those kind words. Why don't we get started? So for 25 years, I've been conducting research on health issues related to injection drug use. I began with response to the HIV epidemic, and have stuck with it long enough to now be dealing with this new challenge to public health for people who use drugs, which is the opiate crisis and attendant overdose deaths and other health elements that I'll discuss in more detail later on. So let me just get started. So I'll talk about how we ended up with this prescription opiate epidemic or crisis. I'll talk about the health consequences of it, and then I'll provide some recommendations about how we might respond to this nationwide crisis. And let me just make a point that, I started with HIV. In the United States, HIV really was relegated mostly to cities in large measure, and I've obviously had an outsized impact on men who have sex with men, and to a lesser extent, people who inject drugs. Although certainly in the Northeast, there was a substantial HIV epidemic among that population too. Part of what distinguishes the prescription opiate epidemic from prior crises is that it really is impacting all of us in all kinds of different settings. So rural, urban, suburban, white, black, Latino, Asian, sort of no one is immune to the consequences of this. And I'll begin to explain why that's the case. So the opiate epidemic basically has it's a three-legged stool. The first leg of the stool was a change in medical practice related to pain. In the early 90s, it was widely conceded that physicians were under-treating pain. And so there was an effort led to sort of change that. So physicians became more interested in treating pain. Now that created some, in the sort of this idea of as pain as a fifth vital sign. And that created some unintended consequences. So one of which is that pain is very subjective. So we all experience it differently. We could have the precisely same injury and have widely different assessments of how much it hurts. And there's not a great understanding of that. Another problem with pain is that typically when someone's prescribed a pain medication, if there's a problem, the recommendation is sort of give them more of that pain medication. And in the face of these sort of new opiate medications, that becomes a real problem. And then finally, there was a real move away from just using opiates to treat acute pain. And so you might think about that if any of you have had your wisdom teeth taken out, you were probably given an opiate kind of pain medication, and they're great for treating acute short-term pain. That's why they're widely used in the military when people are shot or injured. But the move of them into chronic pain created a whole separate set of problems. So that's one stool. Pain is the fifth sign. The other was new technology. So pharmaceutical companies developed these long-acting opiate medications. So the typical opiate medication will last 4 to 6 hours. These new formulations were advertised as lasting 8 to 12 hours, which has some modest advantage. You're sort of taking fewer pills. But I think it's now well documented both in popular literature and the scientific literature that they're not necessarily that long-acting. And some of that just relates back to the issue of pain being a subjective kind of phenomenon. Regardless, they really didn't go through the trouble of establishing that these long-acting approaches were superior to the short-acting formulations. The abuse potential for these medications was not established before they became widely distributed, and in fact, the manufacturers claimed that they had low abuse potential, which we now obviously know is not true. And then, of course, the other piece is that when you use these medications outside the context of either chronic or acute pain, the euphoric effects are substantial. So they make you very high, to put it a different way. And so they're highly desirable as a recreational drug. Then the third leg is pharmaceutical marketing. Now, these are large, multi-billion, large companies, global in nature, billions and billions of dollars of annual revenue and profit. So their capacity to make sure that these medications were widely available to anyone who might possibly need them are really impressive. In the case of one of the manufacturers, there was a successful effort to target physicians, and they began by focusing on physicians with high rates of opiate prescribing. They were spending enormous amounts of money marketing these medications to physicians. In one case, the company spent over $200 million on that. In another year, they reached 90,000 physicians in the United States. Because the distribution system is through medical care, it's sort of available in every zip code or many zip codes. And then lastly, the shift away from acute pain to chronic, which is driven, if you're a pharmaceutical manufacturer, there are real advantages. There's a lot more people with chronic pain than acute pain. And so that shift to using these medications for chronic pain sort of created the circumstance that we're in. So this chart just shows you the massive increase in prescription opiate availability in the United States. And so the way I think about this is essentially what we've created a circumstance of is that for anyone who might misuse opiate prescription medications, they probably had a chance to do so. That could happen through diversion, so someone in their family gets those medications, and doesn't use all of them, so there's some left in the cabinet, the medicine cabinet, and they begin using that way. That could happen from people who have an acute or chronic pain injury who begin to misuse as a way of managing both the pain or of achieving highs. And it's worth pointing out that one of the challenges with these medications is if you continue to have pain, they will prescribe higher doses, which will facilitate this sort of process of becoming physically dependent, which is sort of a unique quality of opiate medication. So if you stop using them, you feel very sick or unwell. And then the other piece of it is that so some patients became misusers from sort of this escalation of treating their pain. The other thing is that if you take these medications for a long time, you can develop a condition called hyperalgesia, which makes you really sensitive to pain. And so so you're sort of caught up in the cycle of, you're hypersensitive to pain. So you start off, you had a pain problem. The medications perhaps dealt with it or didn't deal with it. You took more of it. You're now physically dependent, and then you're even more sensitive to pain. So your desire to take more increases even more. So those are the conditions that sort of have emerged for us. And as a consequence, there's been a response. So one of those responses is the development of these abuse deterrent pill formulations, and the goals of those medications are to not allow you to break the pill down. The reason why people would break the pill down is that if you take a long-acting pill and, say, crush it to snort it or liquefy it to inject it, the euphoric effects are substantially greater. So you get for want of a better term, a better high. So we've had the introduction of these new pill formulations to work against that. Although they're available now. They're in use, but they're still the old kind. They're still available. There's now prescription drug monitoring programs in most states, and what that basically is a repository of all prescriptions given to people. And what it allows physicians to do is if they have a patient in front of them for whom an opiate medication might be indicated, they can look into this prescription drug monitoring website and determine whether the person already has outstanding medications for that. So it's a way of dealing with the issue of doctor shopping and sort of drug seeking in various medical facilities. The other thing is the FDA and cities and states have actually successfully sued prescription opiate makers in a variety of settings. Owing to some of the changing political dynamics in the United States, those settlements have tended to be on the smaller side. And certainly, the last case I looked at, I think a manufacturer agreed to pay West Virginia $25 million. But, they're making billions of dollars on the sale of these drugs. So a $25 million fine here or there is not going to stop them or deter them. So beginning since 2011, we've had this sort of substantial decline in opiate prescribing. The president the other day indicated that he'd like to see that drop another 30%, which sounds well and good, but there's some problems with sort of rapidly removing these medications from circulation now that everyone has sort of been exposed to them. So this chart shows you this is from the National Survey on Drug Use and Health, shows you past year initiation, past year misuse, and past year disorder for prescription opiates, which are in the blue, and heroin, which is in the red. And the key point here is that we're sort of in a pickle now. So we've exposed lots of people. 2 million people initiated prescription opiate misuse in 2016. Another almost 200,000 initiated heroin use. We have nearly 12 million people with past year prescription opiate misuse and nearly 1 million heroin misusers, and then high numbers of people with opiate use disorder and heroin use. So one of the things that's going to happen as we pull back the availability of the legal medications is that people will begin to move into illegal substances. So we've seen, if you just look at the last bullet, a 5-fold increase in the number of heroin users in the last decade. And the reason for that is that heroin is pharmaceutically similar to prescription opiates. It's also less expensive in illegal markets. So in Los Angeles, for instance, you can buy what's effectively a dose of heroin for $10, whereas buying a prescription opiate would cost between $30 and $90, sort of depending on the amount of the milligrams of opiates in the particular pill. Heroin is now widely available in urban settings and is increasingly available in suburban and rural settings to match the market demand that's been sort of created by the pharmaceutical drugs. So, we have a couple reports. We don't have great data on this, and we don't have really good surveillance that allows us to understand transitions between drugs. So even the National Household Survey is a cross-sectional study. There are relatively few local cohorts of non-injecting drug users that we can sort of follow and see how many people are transitioning from opiates to heroin or from heroin to injection. Here's some of the data that's available, at least on that first point of movement of people from prescription misuse to heroin use. So the first study saw about 4% movement in 5 years. Carlson's, which is the most recent study from Ohio, found among prescription opiate users, about 3% of them became heroin users. And then Surratt, looking at a group of club drug users, many of whom were men who had sex with men, saw an annual uptake of 7%. So the thing to think about, though, is that translates into a real number at the population level. So if there are 12 million people with prescription opiate misuse, 5% of them moving into heroin use is a substantial number of people. It's hundreds of thousands of people. And so that's going to continue to be a challenge for us moving forward. So injecting heroin, similar to injecting prescription opiates, creates a better high. There's some forms of heroin. So the heroin that's available west of the Mississippi tends to be black tar heroin. So it's more difficult to use without injecting. And we also know from the National Household Survey that of the people who use heroin, half of them inject it. And that compares to 13% for meth users and cocaine users. So the sort of premise is that we have all these things happening. We have an overdose epidemic. I'll show you data on hepatitis C and HIV outbreaks. There are a variety of other ailments coming with that. But we also have, which has not been talked about, an emerging injection drug use epidemic that's going to have substantial public health consequences. So the way we've looked at this is using local data from San Francisco and Los Angeles, and this is based on sort of two studies I've conducted in the last 8 or 9 years. One's a cross-sectional study. That was the first one in 2011-13, and then I have a cohort study that's ongoing now. And what we've tried to do is sort of bring in some, I guess what I would call sociological context into understanding drug use patterns. So the first one is this sort of idea of drug use generations. And if you sort of survey drug use patterns in the United States, you would see, an evolution of people moving away from heroin in the 60s towards cocaine, and then from cocaine to crack cocaine in the 80s, from crack cocaine to meth in the 90s and 2000s, and then from meth to this prescription opiate stuff, which is sort of in the that really took off in the 2000s. So, and that's sort of the current place we're at, and that's useful to think about because the one of the underlying, I think, principles of drug misuse is that if you're susceptible for drug misuse, you end up using the drugs that are available at the time, and the implication of now having this opiate be the main problematic illicit drug has real consequences because opiate users tend to use for years, not in decades, not months and years, which kind of characterized, the crack, the cocaine, the crack cocaine, and even to a lesser extent the methamphetamine cohort. So people, will start, they'll mess around with it for a while, but typically they'll age out of it, or their life circumstances will change and they'll move out of it, or they'll just get burned out. We know from the earlier generation of heroin users that came out of the Vietnam War era, those folks continued to use for 20, 30, 40, 50 years, and that's what we're looking at now. So we're going to have a problem that's going to go on for a long time. So using this idea about drug use generations is helpful in sort of contextualizing the implications of the change from meth to prescription opiates. The other thing we do is we use this drug set and setting model, which again sort of underscores the need to look at the pharmacokinetic attributes of the drug and how that impacts the use patterns. And I've sort of already described that to you. And then finally, life course theory is helpful in looking at how people age or don't age out of drug use, and then how they remain vulnerable. And, one of the early warning signs of the prescription opiate crisis was the fact that you saw older people requesting medically assisted treatment or opiate substitute treatment in different demographic groups, and that's unusual. Typically, if we're going to misuse drugs, we will misuse them through our 20s, but most folks age out of it. And so when you begin seeing 40 and 50-year-olds requesting treatment for methadone or buprenorphine, then you know that you've got a different, you've changed the life course framework of drug use in the United States. All right, so I've sort of briefly described the studies. The first one's cross-sectional, the second is a cohort study. We're in the midst of still collecting our 6-month and 12-month data for that. So the characteristics of my sample, mostly male, a little less than between 15-20% gay, lesbian, or bisexual, mostly white, but with decent representation of Latinos and African Americans. The population I see is largely homeless, and one of the next things I'll be working on is this big jump in the prevalence of homelessness, which went from 60% in the 2011-13 sample to 80%, over 80% in the 2016-17, and then we're also seeing basically a doubling of younger people between the two studies. All right, so part of what we've done with this work is just begin to map on that this population of people who inject drugs actually can give us a window into understanding national drug use trends. And so this slide just sort of is my attempt to sort of match those two things. So what you see is the proportion of the sample that report using this drug for the first time by half decades. And you see we have a heroin peak in the late 60s that's then replaced by a cocaine peak in the late 70s, and then a crack cocaine peak in the late 80s, and then meth jumps up, and then you see meth being surpassed by prescription opiates going into this last period, 2005 to 2009. So I think this sort of makes the case for saying, yeah, it's reasonable to use this kind of sample using their retrospective reports to sort of understand national drug use trends. So the first question is, what are the implications of having prescription opiates be the sort of main illicit drug that people are using now? And this shows you one of those that change. So one of the implications is the move of prescription opiates from being relatively infrequent initiator of opiate use. Most folks started in the 80s. And so what this shows you, and I'll try and explain, it's a little bit complicated, is that the first column, the pre-60s generation, so this shows that about 12% of them or 15% of them started their opiate use with prescription medications. And then most of those started with heroin, which was this middle one, and then at the same age. And then if you just look at the first bar in each column, you see it grows substantially. So by the 1980s, nearly 70% of people, their first opiate is the prescription drug, or they're using them in the same year, which is the one on the far right. So that's a big change, and part of the implication of that is, again, heroin is not widely available, although increasingly it is. Prescription opiates are everywhere, and so that's what's sort of driving this, is that you get this sort of generational switch in drug use patterns. And this is sort of another way of representing this. Now, this is looking at the first drug injected. And what we see here is the top line is heroin, and the bottom line is cocaine or meth. And so again, reflecting these sort of drug use patterns, the first drug injected was increasingly a speedy drug, so cocaine or meth. But then as these new cohorts come on, you see it begins to go down, and instead we have heroin becoming the first drug we inject. And if we drew another line out, from the 90s, we didn't have a lot of people in the sample who were born in the 90s, but the number continues to go up. So we're going to have more heroin injection as a consequence, as a sort of follow-on from the prescription opiate crisis. So then the next thing, again, trying to make the point about how opiates leading to heroin, leading to injection sort of changes the injection drug use epidemiology in the country. So we sort of developed two measures. One of them is one is sort of time to injection, and that's a broader measure focused on how old were you when you first used an illicit drug, and then you first injected any drug. Right, so that's just one measure of time. That's one time to injection. And then we have a second one that asks the question, when you first used any drug, how long was it before you injected it? And all of this, the take-home for this will be largely that the uptake of heroin means that we're going to end up with a lot more injection drug users moving forward. So just looking again, remembering that we had this change of people using more heroin injection. This is the overall time from first use to injection by birth cohort again. And you see it was pretty low for the pre-60s generation that was mostly exposed to heroin, and then went up with cocaine and crack cocaine, and now it's going down again. And, you know, we'll be able to look at this in my new sample, which has many more people born in the 90s, but I would expect that the bars for the folks born, the age cohort born in the 1990s would be even shorter. And then this just sort of looks at that using multivariate regression. This is a linear regression model with time to injection as the dependent variable. And the key thing here is if you just look at the bottom two rows, we see there's a negative number with the 1970s as a referent. And what this indicates is that folks born in the 80s had significantly shorter times to injection as compared to folks born in the 70s, which sort of reinforces that point. All right, so then we use survival analysis techniques to look at time from first use to first injection. And again, this sort of shows this unhappy story. With heroin users, median survival time is a little more than a half a year. So from your first use of heroin to your first injection, less than a year. It's over a year for speed, and then much longer for the cocaine and crack cocaine. And then within 10 years of first use, 93% of the heroin users will have injected, as compared to 78% for meth and 70% for cocaine users, and then 30% for crack cocaine users. And then last, this is just a representation of data again. And the point of this is just to show that a lot of that action really is in the first year. So the slopes on these lines are not significantly different. But what is different is the entry point. So that first year of use and it seems to inevitably lead to injection for most heroin users. All right, so the opiate epidemic associated with more rapid transition to injection drug use, and the people using heroin, which is the drug that sort of follows on naturally for prescription opiates, are going to end up injecting. All right, so one of the problems with having more injectors is that in a way, injection begets additional injection. And so let me explain what I mean by that. So we conducted that initial study, 2011 to 13, was a study on basically asked the question, how do people become injection drug users? And what we found was that it isn't it's a process. It's a social learning process. So folks the stories that people told us about their pathway to injection involved exposure to injectable drugs, being around people who injected drugs, an opportunity to receive instruction in injection, and then actually getting assistance injecting. Most of us don't like getting shots. We're needle phobic. It's difficult to hurt yourself intentionally, which injection requires. And so basically 70 to 90% of the people who ever inject need help injecting that first time. And so this sort of social learning process sort of summarizes that process. So we've asked questions of people like do they encourage others to inject drugs? Do they inject in front of non-injectors? Do they prescribe injection to non-injecting? Understanding that these are potentially precursors to injection drug use for non-injectors. And what this shows you is that these sort of precursor behaviors are associated with initiating people. So if you've ever described injecting to someone, you're more likely to have initiated someone in the past 12 months. We also looked at whether you're being asked, and that sort of is a good measure of that the person who currently injects is sort of involved in that social learning process. And what this basically just shows is that when you do these precursor behaviors, when you inject in front of non-injectors, when you describe injecting to non-injectors, or when you do both, you're going to be much more likely to be asked to initiate someone for the first time. And this is sort of as a figure that sort of shows that, again, the bottom one is ever initiated someone. If you're not injecting in front of non-injectors, if you're not describing it, if you're not doing both, you're very, very low probability of initiating someone, either in the last 12 months or ever, which is the middle line, and then you see the thing about being asked, which is the top line. Okay, so one of the things that's disturbing We know that heroin use has increased based on the national surveys. The data that we've collected in San Francisco and Los Angeles indicates that injection, both from the changes in the demographics of our sample, but also in the self-reports from people who currently inject, it looks like there's more initiation going on. So you can see these are comparing the 2011-13 sample to the 2016-2017 sample. Recent initiation was 7% in the earlier sample. It's 13% in the newer one, and we changed the question. So the question in the newer one is for the last 6 months. So that number, if it was annualized, would probably be higher. Describing injections gone down, but injecting in front of non-injectors has gone up, and that probably has something to do with the increased homelessness. And then a willingness to initiate people in the future is basically equivalent. So just so you know, I am trying to do something about that. In my current study, the sort of second one is a short, hour-long, active listening, motivational interviewing intervention with current injection drug users to sensitize them to the risk of this sort of precursor behavior, and then to provide them with behavioral skills and role-playing opportunities to sort of figure out how to get out of those situations if they find themselves in them. All right. So what are the consequences of all of this? That they're relatively horrific. In 2015, Scott County, which has about 40,000 people in it, had an outbreak of HIV and hepatitis C among the people who inject drugs there. So they had 183 infections in a year. Just to give you an idea, LA County, which has 14 million people in it, had 56 injection drug use related HIV cases in that same period of time. So 40,000 people with 183 HIV infections to 56 with 13 million people. There are documented outbreaks of hepatitis C in Kentucky, Tennessee, Virginia, and West Virginia. Most of those cases now, because we have a clean drug supply, are going to be from injecting drugs, so sharing syringes or sharing cookers, cotton, or other drug use injection paraphernalia. HIV incidence has increased among young people in non-urban counties. We've seen dramatic increases in abscesses, so skin and soft tissue infections that are often associated with injection drug use. We've had these increases nationally in North Carolina in hospitalization for infective endocarditis related to drug injection. We're seeing this age cohort difference now. So acute hepatitis C rates have increased among young adults. And so the difference between an acute hepatitis C case and a chronic hepatitis C case is acute case is new. So those are folks who've been infected in the last 6 months. Dramatic increases after long-standing declines among all populations. Again, that tracks with the increasing evidence of more drug injection in the United States. This is data from California showing the age distribution of chronic hepatitis C cases. So we went from having a nice little bell curve or one-hump camel to now emerging to have a two-hump camel as younger people begin to increasingly become infected with hepatitis C. And then you can see this is some representation. If it's darker, means more hepatitis C. And this sort of underscores, again, the almost global impact, it's sort of hitting everywhere. So we have increases in Los Angeles, which are the quintessential urban community in California, increases in the Bay Area, but also increases in these sort of urban or rural areas in Northern California, where folks are moving, or have been exposed to prescription opiates, are misusing them through injection or perhaps transitioning to heroin if that's available in their local communities. And then there's been a lot of talk about the overdose deaths. So there's sort of two qualities of this. Earlier I made the point about as we pull back prescription opiates, we do run the danger of people moving to the illegal alternatives, and that's happened. So you see this reflected in the heroin overdose deaths. Beginning in 2010, how they've gone up dramatically. And then the thing that began to happen in 2013 is that the heroin supply became contaminated with synthetic synthetic opiates, the main one being fentanyl. This is a problem because fentanyl is 10 to 50 times more powerful than heroin, so the risk of overdose increases dramatically. And that it's a sort of contamination thing. So folks don't, this may change, but at the moment, for instance, in Los Angeles, folks aren't buying fentanyl, they're buying heroin, but it's been contaminated with fentanyl, and this is sort of happening throughout the country. So we have these HIV, hepatitis C outbreaks, we have the overdose crisis, the contaminated drug supply, increasing drug injection, and a treatment system in the 25 years I've been doing this stuff that has not increased to match the problem. And so we're poorly prepared to deal with this. But we do have lots of options. So let me just start with the first principle, which is that we need many approaches, not just one. And, as you follow this debate in the newspaper or as you talk to local decision makers or state decision makers or even national decision makers, keep in mind that there isn't one solution to this. So we're going to need to sort of open the full box and take a look at all kinds of different options. So this was a cascade approach that we developed. We weren't able to test it, but we did. A couple of colleagues of mine, Pete Davidson, who's at UC San Diego, Shoshana Scholar, who now works for the LA County, and Carl Castro, who runs our military health center here at USC. We put this together just looking at this, and the idea is just to highlight the different kinds of choices. If you're trying to deal with diversion, you might want locked cabinets or lockable pill boxes. If you have patient-driven diversion, you might want to use peer referral to injection drug use. To drug treatment rather. If people are selling them, you might want to get someone a job so they don't have to sell drugs instead. If they're self-medication, get them additional treatment, provide them with overdose prevention training or naloxone, and then referral to drug treatment. So there are lots of things to do. I'm just going to take you through a little bit of a laundry list of what some of those things might be. So we can do demand interventions to prevent injection initiation. So part of that would be making drug treatment more widely available. But there are some sort of cognitive behavioral interventions, the one that Don Desjardins did back in the 90s, that sort of try to arm current non-injectors with information about how to about why they wouldn't want it, why they don't want to become injection drug users. There's these combined structural interventions that Daniel Werb, who's at UC San Diego and the University of Toronto, is exploring, which looks at combinations of drug consumption rooms, increased medically assisted treatment, housing first, and decriminalization of illegal drugs. We can do what I'm doing with the existing population of injectors and try and move them away from facilitating injection uptake. And I've already described that to you. The middle bullet is the one we're doing, which is change the cycle. Now, obviously, naloxone distribution has been very important. The peer drug users and drug injectors are among the most effective respondents to overdose. They know what it looks like. If you arm them with naloxone, they've shown over and over again they're more than happy to use it, and have probably been very effective. And we're sort of collecting more and more data about this, about how effective this sort of approach has been to preventing overdose deaths. And then we spread first responders now. Obviously, paramedics have been carrying naloxone for years, but now police are increasingly carrying it as well. And you can see this just shows the rapid uptake now and distribution of naloxone in the country. So it's an important development. So here we used the data again from our 2011-13 sample and 2016-17. So the lighter is the later one, and then these are broken out by city. And the key thing here is just to note that we've seen increases in overdose between the two samples, probably in part because of the fentanyl contamination. Many people who inject drugs witness overdoses, so they've gone up dramatically in Los Angeles. But most importantly, we've also increased the naloxone distribution. And so it went from being used 4% of the time when someone observed an overdose to almost 70% of the time. So this shows you the power of drug users to be health interventionists in the midst of this particular crisis. And the same thing has happened in San Francisco. San Francisco had a higher baseline of naloxone distribution, but now 90% of the witnessed overdoses, someone in the community is reversing that with naloxone, which is a tremendous health benefit. The other hot topic is the safe injection rooms. They accomplish a variety of things. So there are about 100 in the world. No one's ever died in one of them. I've visited probably 4 or 5 of them over the years. They're sort of clean, well-lit places to use drugs. They're very effective at preventing overdose deaths. They've been documented to provide a great avenue into services, including substance abuse treatment and housing. They obviously, because people are using alone, reduce any risk of HIV or hepatitis C transmission. Because the setting is clean, you should see declines in infective endocarditis and abscesses. And then finally, because people aren't using out in the community, they're using the facilities, that reduces the socializing aspect. So, in fact, in Switzerland, they have had safe consumption sites for many years, since the 90s, and in fact do heroin prescribing, and have seen a dramatic decline in their population of drug injectors, because the current cohort of people who don't use in the community. They use in this facility, and so they're not in a position to socialize others into that kind of use. Of course, we need to expand treatment dramatically. There are a whole set of regulatory and legal impediments to that we need to overcome. In fact, I was having a conversation with a pharmaceutical manufacturer earlier today, and learned of a new way in which we sort of prevent ourselves from making these evidence-based treatments as widely available as they need. For me, the gold standard really has to be that we need to make legal treatments or substitutions as readily available as the illegal drugs are, and less expensive than them. So right now in Los Angeles, it's a lot easier for you to get heroin than it is for you to get drug treatment, and we need to change that. And this just sort of underscores that point. We've had, there's been great progress in improving methadone availability and buprenorphine, but if you refer back to my earlier slide, remember, there are almost 2 million people last year that had prescription opiate disorder, and another 700,000 that heroin use disorder, and there are only 400,000 methadone slots. Similarly, there are only 55,000 buprenorphine slots. So that capacity is insufficient to meet the demand that we have. And then this is just a little list of different things you can do and how they deal with the sort of downstream consequences of the opiate epidemic, including drug injection, these HIV outbreaks, overdoses, and fentanyl. There are a lot of things that we can do, and we need to move on it quickly. What I'd like to see, and what I would have liked to have seen yesterday when the President was addressing this topic, is a response like we saw for the AIDS epidemic, where billions of dollars were put into the fight to develop new medications, to provide preventive services, to make sure people have access to care. And we've made tremendous improvements in that. HIV is now a chronic ailment. Most people, certainly in developed countries, receive care. Many people in developed countries now receive care. And that's sort of what we need to look for in terms of the prescription opiate crisis. Let me just conclude by acknowledging funding from the National Institute of Drug Abuse, our project officers, my best friend and collaborator, Alex Kroll, and then the community participants, research assistants, students at USC who have all contributed to this work. Thank you for your attention. So we'll do questions now?
Yes, thank you, Dr. Bluthenthal, for sharing that information. We will now try to answer your questions. To submit a question, please type it into the Q&A box in the lower right-hand corner of your screen and hit send. Dr. Bluthenthal, he shared a lot of very important information with us, and he's happy to answer any questions that you have. We do have one question right now, Dr. Bluthenthal. One of our attendees asked, can you briefly describe a little bit more about the pharmacogenomics and the opioid epidemic, and where are we with that?
probably not. I'm not sure what pharmacogenetics are. Can you give me a little bit more about that?
I'm so sorry. The pharmacogenomics and the opioid.
Yeah, no, I don't know what that is. So tell me what that is, and then I will try to answer it. Sorry.
Okay, no problem. We will move on to our next question. Our next question is, what's considered abuse of opioid use if an individual's tolerance is higher than average users?
Yeah, I mean, I think, basically, there are a couple of definitions of addiction out there. Typically it means, for want of a better term, the short term would be sort of, repeated use with negative consequences. So you're using so much that you can't do the normal things that you would typically do. So you can have situations where someone is dependent on an opiate, but it not be addiction. And so cases like that might include folks who are terminal cancer patients, and so they're taking it for pain relief, for the cancer. They're dependent on it, but it wouldn't be considered addictive behavior because it's used to sort of deal with the sort of in-life moment that they're going through. The issue is really what are the other things happening around you that lead to negative consequences, whether it be driving high or missing work or selling your toaster. And so here's one. So how does genes, so this is the pharmacogenetics. Thank you, Rydell. So how does that affect a person's response to drugs? So thank you for clarifying that. I do not know the answer to that question. Let me just tell you what I think generically about genetic explanations for substance abuse, which is that I'm sure that there is some contribution, and we know that there's some genetic markers, for instance, for alcohol, and we know there's some genetic predispositions that certain populations have that make alcohol use more problematic for them. Those probably do exist for opiate medications as well. I'm a sociologist. The part of the problem I'm focused on more is the other dynamics, which is that regardless of what your genetic profile is, if you've been exposed to these drugs and you begin to misuse them, we do have relatively consistent outcomes from that. And the genetic contribution to that, as far as I know, is certainly not well understood. Should I just keep going through the list? Jennifer Yang,
Sure.
Can we treat opiate abuse as a chronic disease? Well, yeah, it is a chronic disease, that's for sure. I think one of the areas that people are going to really begin focusing on is that pain is a chronic ailment, and we need to come up with other ways of treating pain that don't involve prescribing folks drugs that are highly addictive. Let's see here. Should I just keep going, guys, or?
Absolutely, Dr. Bluthenthal.
Okay. And then there's a question from Douglas about what are your thoughts on how the opiate epidemic affects state and federal public health policy for treatment conditions are concerned. Okay. So I actually learned something about this today. So I will try and share this with you. And there are a couple of thoughts related to it, and I'll end with the thing that I learned today. Okay. So the first thing one of the problems that we've had, I talked about medically assisted treatment, so that's methadone and then buprenorphine. Those are the two main medically assisted treatments. They're highly desirable because they really are effective. So people who use these medications, their use of illicit drugs go down substantially. There are great benefits in terms of employment and housing and social, their ability to sort of have lives that look like they don't have any drug use history. So they're really powerful that way. Unfortunately, they've also been heavily regulated. There have been changes most recently in the legal status who can prescribe. So, for instance, there was just a new directive that came out a couple of months ago from the federal government that now allows nurse practitioners and physician assistants to also prescribe buprenorphine. So that could be very helpful moving forward. Now, one problem is, so we have this Medicare system and Medicaid expansion, so many more, and we also have parity. So, substance abuse, which is a mental health illness, should be treated the same way as a broken arm in terms of availability of treatment. But there's a thing that sort of happens behind the system that gets in the way of that. So let me tell you this. So this is a new thing I learned. So there are these things called pharmacy benefit management organizations that basically create the pharmacy formulary. So that's the drugs that a provider can use to treat, X, Y, and Z. And because of market dynamics in that system, some of the best kinds of and most innovative substitution medications actually aren't available through people's health insurance. And the example I learned of today was this drug, this buprenorphine alternative called Bluthenthal, which is, it's a Suboxone. So it's a buprenorphine medication that you use as a film. So it's just like a little piece of paper that you ingest. Has lower side effects, but it isn't widely available because the manufacturer of them hasn't been able to get through the pharmacy benefit management companies to make it available through insurance. So I think one of the things that we have to look at both the state and federal level is how do we, it's going to be crazy to say this, but how do we deregulate these medications so that they can be made widely available to people that need them? Because there's a bottleneck at that level as well. So it's very hard to get people in drug treatment. Like I said, it's much easier to get heroin than it is to get a drug treatment, and we need to sort of change that. Okay, so in terms of, Cy Provost, that's a great name, ask, how do we advocate for more treatments? Is it lack in terms of beds or funding? So I think there's a lack. What would have been great to hear from the President yesterday is, here's a pot of money for evidence-based treatment. States can draw on it as rapidly as they can get patients into these kinds of evidence-based treatment. So there's a money problem, and then on the other side, there's a regulatory problem. One thing I didn't mention is, folks don't, and maybe in your own communities you've seen this, people don't like having methadone clinics around them, so they can be hard to cite. Part of the advantage of the buprenorphine medications is that they're designed to be given out by primary care physicians, so you don't end up generating the NIMBYism piece, but there are still barriers to making buprenorphine widely available. But we need more money. We need physician attention and willingness to address this problem. We need folks to understand all the multiple barriers to drug treatment entry that they have. I mean, another issue that's current in the population I see is that generally speaking, methadone doesn't have a great reputation among heroin users. And many people think of buprenorphine as very similar to methadone. And in fact, it actually isn't, in that it's a longer acting. It has much less abuse potential or diversion potential for naive people, and it has what's called respiratory ceiling effect. So it's pretty protective against overdose. So figuring out the policy solutions that allow these medications to be prescribed through insurances and paid for, and then dealing with the sort of barriers to use among people with these substance use problems would be another thing to look at. So can we get abuse with treatment use? Yes. So we need more treatment. All right. And let's see, Jennifer Yang. More integrative care team, sure. That's not a bad idea. But I do want to emphasize again what I see. So if we go back to the slide where I presented the demographic characteristics of the population, 80% homeless, right? So we need a system of care for them that's going to make it easy for homeless chronic drug users to get the health care they need. So it's less of an issue of When they get into the system, is the team integrated? That'd be great, but we can't get them into the system at all. And so there's a lot of untreated people who I know from my many years of doing this work would be happy to receive treatment. We just make it really hard for them to get it. And so we really need to rethink how we provide care to this population and think about it in terms of what's the lowest, easiest way we can make it for them to get these life-saving medications. So I think I've answered the questions that have been listed. Are there others?
I don't see any others, Dr. Bluthenthal. So thank you so much for answering all of those questions for us this afternoon. I want to thank you, Dr. Bluthenthal. I would like to thank Dr. Kumar as well as Caroline for joining us today. And I'd also like to thank everyone who participated in today's webinar. If you have any additional questions or, as a prospective student, if you think that it's time to apply, please reach out to either myself or one of our other advisors. A copy of this recording and our slide presentation will be available shortly after. This definitely concludes today's webinar, and I want to thank you again for joining, and you all have a wonderful rest of the day.